Okay, so thank you very much for joining me today. Let me just check whether the net connection and everything is okay. Yeah, it's good. So good morning. Welcome to Imaging Study. It's not morning, actually. It's evening here. But many parts of the world from where you are watching, maybe early morning or even the afternoon. So thank you for joining me. Welcome to Imaging Study. Like previous sessions, today we are going to show you 5 ultrasound cases, and obviously after the end of these 5 cases, we will love to go for the bonus component or bonus topic, which will be obstetric related thing. So if you are interested in obstetric imaging, definitely it will be helpful for you. And we have 5 cases today, and the last case will be the larger one. I think only a single case will cover around 50 slides. So that's a big case. And yeah, many of you who follow me on Facebook or somewhere already know or may suspect the case. So let's enjoy the rest of the cases. So, walaikum assalam. Thank you for joining. So, let's start with the case number 1. So, before starting, I would love to recommend you my YouTube channel named Imaging Study. We all have already uploaded our previous sessions there. So, if you are interested, you can just check them on Imaging Study. We have already got 61K plus subscribers. So, thank you for joining us there. And we have already uploaded for 70 videos there. So, many of them may be helpful for you. So if our content makes you happy, makes you interested on ultrasound, or maybe it will be helpful for many of you who are not having good case demonstration. So if you find them helpful, please don't forget to share them. And obviously, don't forget to share this video also, so that we can reach more people. Many of you think that these YouTube contents are very rich, and these are very money earning videos like thing. So yeah, our videos are monetized, but the earning that we get from these videos is very small. Like what I earn from the whole year from this YouTube contents is actually less than what I earn, I think, from my practice in a week. So that's why we actually not working this for money. We are doing it for fun. We are doing it to share our knowledge with many people who are not getting actual case exposure. So if you find these videos helpful, please don't forget to share with others. So maybe it will be helpful for many people who are searching for this. So let's jump into the case number 1. It's a 19-year-old female patient who came with a dysmenorrhea. Let's see what we have got on ultrasound. Unfortunately, I'm not showing this case for the pelvic organs, but yeah, this patient had some pelvic organ features. So this was the feature of a uterus. It's 4 centimeter in anteposterior diameter, which is a slight bulky for a young unmarried patient. So the uterus is slightly bulky, but this is not my thing for today. And when we reach the uterus on transverse section, try to little magnify. Yeah, urinary bladder is slightly filled, so it's good, but the uterus is slightly enlarged, so that's why it's not suitable for the bladder to show a better quality image. Make sure this patient is unmarried, so due to intact hymen, transvaginal sonography is not recommended in this patient, or maybe we are not trying to do that. So we check the patient with transabdominal scan, and you can see the myometrium is showing some multiple echogenic stripes. These echogenic stripes are highly suggesting it to be a case of adenomyosis. And to confirm it, we use the color Doppler. You know, in color Doppler, when we see this type of echogenic stripes on color Doppler, we see some interesting type of vascularity, which we call the speckled appearance. So this is the typical speckled appearance vascularity. So let's see another view. So this was the uterus, and this is the speckled vascularity, some unusual type of vascularity we see in the myometrium in a case of adenomyosis. But this is not the case of what we are trying to show you. So let's look at the upper abdomen of this patient. So when we jumped into the gallbladder, make sure this is not from a very big town. This is from the rural area. So when we look at this gallbladder, and inside the gallbladder, you can see an echogenic linear structure within it. So first thing that should come in your mind looking at this picture when you are scanning in a rural area is the worm. So uh, on our first impression, we thought about the echogenic worm within the gallbladder. But usually when a worm gets calcified or gets dead inside the gallbladder, it should be in the dependent position. Yeah. So this is the dependent part, but this echogenic structure is not located at the dependent part. So it is floating. So that took our attention, and we want to evaluate it a little further. So let's look at it from a different angle. So when we look at it from different angle with different preset, we found something else also. So you can see similar echogenicity structures are also seen here in this anchoal and also around at the neck. So yeah, it might be a fragmented structure, but hey, look at here. Just let me freeze the image, just go a little backward, and the lesion is getting originated from this posterior wall. So this is not the worm, rather you can see multiple polyps here. So this elongated structure is unfortunately not the worm, rather it is a gallbladder polyp. So we have got multiple polyps here, and this polyp is mimicking the gallbladder worm. Okay, so that was unusual. So let's look at it from different angles. So now you can see multiple polypoid lesions on cross section. So looking at the gallbladder from different angles and different sections may help you understand the exact pathology going on here. So now you can see here is a polyp here. Let me freeze the image a little. So now you can see it is getting originated from this wall, and the elongated one that you have seen before is getting originated from this wall. So these are not the gallbladder worm, rather these are actually gallbladder polyps. So here the pictures, and you can see this is the gallbladder worm-like polyp arising from the posterior wall near the fundus, and here's the picture. So we have measured it, and yeah, it's not big enough in the thickness, but it's definitely an elongated polyp within the gallbladder. Here's again the picture. So these are the gallbladder polyps. This was a case of uterine adenomyosis along with gallbladder polyps. Okay, so now let's jump into the case number 2. So this is a 41-year-old female patient who came with pervaginal bleeding. Okay, so no, sorry, not pervaginal bleeding, rather it's pervaginal discharge. So let's see what we have got on ultrasound. So here's the transverse section. Make sure the urinary bladder is partially filled. So we are looking at the cervical part. The body part is not well visualized here. Again, this was a retroverted uterus, so this part is not well understandable. So this is making some confusion, but let's look at the confusing parts. So when you are looking at the central part of the cervix and the lower part, so you can see some internal endometrial abnormality, like some cystic areas, some echogenic parts, some thickening like thing. So there's something abnormality going on there. So let's look at it from different angles. So this is the cross section of the cervical region or lower uterine part. Now you can also see some echogenic area with internal cystic spaces. So there might be some cervical mass or cervical endometrial hyperplasia or something else. So what you can do, let's see it on transvaginal ultrasound. So we have, here's the picture, and you can see this heterogeneous area within the cervical central part. So let's see it on transvaginal ultrasound. So here's the picture of the transvaginal ultrasound on the longitudinal and transverse section. So here you can see it's a retroverted uterus. This is the endometrium here in the body level. And we can see some cystic areas in the cervix. Nabothian cyst is a very common finding. So we hope that will be the Nabothian cyst. So, but unfortunately, there is something else going on here. So let's see it on transverse section. Now, this is the transverse section of the cervical region. And here you can see there is a heterogeneous mass-like area. You see this mass-like area here with internal cystic appearance. You can see some fluid collection adjacent to it. Maybe these are also cystic areas. Yeah, this should be the cystic areas, not the collection. So how can you confirm? You do the longitudinal section and you can confirm it. So now we have some differentials. We want to exclude the endometrial hyperplasia at the cervical region. We want to exclude the endometrial polyp. There is a big differential about the endometrial mass. Yeah, these are the common things. Now, if we'll use the color Doppler to confirm it. Now, if it is a mass, on color Doppler, you will get multiple feeding vessels here. So many vessels will supply this lesion because this cervical malignancy is a very notorious thing. If it is endometrial hyperplasia, you may get some vascularity, but it is a regular vascularity of the endometrium, nothing else. If it is a polyp, then you will see a single feeding artery, which is very important finding. A single feeding artery will supply this lesion. So now we want to see on Doppler whether it is getting supply from a single vessel, or it is getting supply from multiple vessel with aggressive nature, or some light nature for endometrial hyperplasia. Let's see on color Doppler. So here we have put color Doppler. Now you can see multiple vessels, okay, but it is cross section. So you should check it on longitudinal section. Like on longitudinal section, yeah, let me freeze the image. Yeah, this is the feeding vessel. Oh, sorry. So just freeze the image at this point. Now you can see a single feeding artery. So this is called the single feeding artery sign or single artery sign. So this single feeding artery is supplying this lesion. So this lesion should be an endometrial polyp. As it is located at the cervical region, we call it endocervical polyp. This can be a palpable or this can be examined per vaginally. So my clinician, I think she knows about this thing. Uh, so as it is getting supplied from a single artery, so we'll definitely go for the cervical polyp. Now my clinician will go and evaluate it, whether it's a benign polyp or malignant one, but possibly it should be counted as a benign lesion. So here's the picture. You can see the transverse measurement. So the measurement is not very accurate here, I think, and it is getting supply from a single feeding artery. Okay, so we have took sample from this vessel, and you can see some flow here, monophasic flow, with around 25 centimeter per second of peak systolic velocity. So this is a case of cervical polyp, or we can more precisely say it as an endocervical polyp. Okay, so let's jump into the case number 3. This is a 58-year-old male patient. So this is a urogenital case, and you can see the patient came with painful penile swelling with difficulty in maturation. Right now, I'm actually having some stressful life for last 2 days, yesterday and today. In the last Wednesday, I had 2 patients, they're friends, and they came to me for the penile Doppler ultrasound for erectile dysfunction. I used the papaverine, which is very common. And for the first time in my life, both patients developed priapism, which is very unusual. And unfortunately, after injection, we usually suggest the patient to stay in the hospital for at least 2 to 4 hours until the penis gets normal in position. but after the examination, they actually left the hospital. They came to me after 1 day and with a painful erection, which was very crazy. Fortunately, my friend, who is a very good urologist, helped me to solve this case, and I referred them to him 2 cases of priapism at the same time. So he actually managed those cases in the operation theater, which is crazy. And fortunately, they got their pain relieved. I don't know about how the prognosis will go on. So hopefully, we will share that with you in the future. Okay, so that's a very traumatic case for me and for the patients. Unfortunately, the clinician who seen the patient, he said that I'm not responsible for anything like that. So just contact with your radiologist who will solve this. So that's a very critical condition because we actually took attention from our clinician that this case may have some problem after the examination. So we have no facility to solve that because I work in a diagnostic, not in a dedicated hospital. Okay, so anyway, so we'll share the update with you in our next contents. So let's jump into this case. So painful swelling, and he had difficulty in maturation. So 58 years old male patient. Let's jump into that. So here's the high frequency scan of the penile region. Oh, what was that? So this is the corpus spongiosum. You know, in corpus spongiosum, we see the ureter. So this dilated cystic structure should be the ureter. Let me show you it later. So that's interesting. So the penile skin is quite thickened. You can see something there. So this is the corpus spongiosum. Let me freeze the image just for a tiny anatomy. So I'm just move the transducer to the ventral part of the penis. So this is the corpus cavernosum, this is the corpus cavernosum, and this is the corpus spongiosum. So something is going on here. So that was a complicated case, I think. Okay, so you can see here is a lesion here. So this is a cystic lesion, and yeah, this cystic lesion is, I think, compressing the corpus spongiosum. That's why there is a urethral dilatation. So this is the reason for the urinary complaint of this patient. But what is this? This is a cystic lesion with internal echogenic debris. So let me look at this lesion quite well. So here you can see, yeah, this is the corpus spongiosum. So it is in the lower part, I think. So you can see internal debris, some sediments, and this is the dilated ureter within the corpus spongiosum. So that means this lesion is compressing the corpus spongiosum here. That's why you are getting the urethral dilatation. Proximal urethra is getting dilated. So what can it be? You can see the skin thickening with some fat plane irregularity. So this lesion should be counted as penile abscess. You know, it's a penile skin abscess, not from the urethra, but it is compressing the corpus spongiosum. So urethral dilatation is very common association. So now you can see what's going on here. When I use the transducer, put the transducer over this lesion, you can see some movements here like the spermatocele, but this is not the spermatocele. So you're seeing at the lesion, and this is called the acoustic streaming. You know, when we put the transducer, linear transducer, especially over a structure, the sound beams will create a vibration. So these sediments are moving along the vibration, and it is called the acoustic streaming. So you can see the sediment here, and this whole lesion is a penile skin abscess. So here's the lesion from different angle, and you can see this is the corpus spongiosum, and in long section you can see the dilated urethra here. So it is getting compressed. Let me freeze a little. Sorry. So I think I have crossed that. So just to ensure you the actual view, you see this is the urethra. Look at here. So just here, this is the urethra here. So this is the tiny part, and this is the lesion here. So which is compressing the urethra. So that's why the proximal part is dilated. So this is a case of penile skin abscess. Okay, so here's the again the picture of the acoustic streaming. If you haven't seen it before, make sure to put it over any hydrocele and you can see that very clearly. Okay, so we have put color Doppler, and now you can see this acoustic streaming as a color artifact, and you can see this movement. So this is not an aneurysm. You can't make an aneurysm in the penis quite easily unless there is a trauma or something like that. So the patient is having a very painful acute condition, and this is the penile skin abscess. I don't know how he made this penile abscess actually. So there is a penile abscess, and you can see penile skin abscess, and you can see it's around 3.5 centimeter long. So this is a big abscess. And this is the dilated urethra, the proximal part, penile urethra. So this is a penile skin abscess compressing the corpus spongiosum at that site, causing the urethral dilatation. So this is the lesion here. Okay, now let's jump into the case number 4. I'm actually getting crazy about the case number 5. So if you are very busy, don't forget to miss that case. So this is a 55-year-old female patient who came with a raised serum creatinine. So let's see what we have got on ultrasound. So here's the picture of the liver and the right kidney. It doesn't matter how you measure it, but look at the kidney. It doesn't look quite normal, though I didn't take any good picture, but yeah, it's still small sized kidney. So let's see this kidney quite well on the real time. So here's the picture on real time. It's still the small sized kidney, but when you are looking at the kidney, you can see the ecotexture is not quite good. Rather, you can see the cortical eco, no, not the cortical, cortex looks quite good. The medullary echogenicity is quite increased, and you can see this increased echogenicity is covering the pyramids. Now let me freeze the image in a any part. So yeah, okay. So you can see this is the renal pyramid, and you can see the echogenicity around the pyramid. So this echogenicity around the pyramid is a very important feature of early case of nephrocalcinosis. So we want to see it whether it's a nephrocalcinosis case. So let's see the view of the right kidney here. And yeah, it looks like a nephrocalcinosis, but for confirming it, we want to see the opposite kidney because medullary nephrocalcinosis is mostly bilateral. Okay, so let's look at here. So if it is unilateral, renal tubular something lesions, lesions are very common. So we'll go for them. Here, this is the picture of the left kidney, and on left kidney, you can see the similar features here. So you can see the increased echogenicity of the renal medulla. So this is the case of bilateral medullary nephrocalcinosis. Here's again another view, a little magnified, and now you can see this increased echogenicity of the renal medulla. Around the pyramids, this is a case of medullary nephrocalcinosis. This kidney is quite normal in size. In my country, the kidney size is considered normal for at 8 to 12 centimeter length. So it may vary from country to country. Obviously, it depends on the height and body status. So for my country, it's quite normal in size. So here's the picture. And if, yeah, it's a echogenic medullary nephrocalcinosis. So this is a case of bilateral medullary nephrocalcinosis. If you are interested, there are 4 grades of medullary nephrocalcinosis from 0 to 3. So yeah, CT scan is a very excellent technique, but for grade grade 1 and grade 2, it's a little bit difficult to evaluate in CT, but grade 2 is quite easily understandable on CT. Grade 1 is a little bit difficult. So for both cases, ultrasound is a very good technique to evaluate. So comparing the ultrasound with our CT may give a very good evaluation. Okay. So let's jump into case number 5. So before jumping into case number 5, let me just check a little, checking whether there is any important point. Okay, so let's jump into case number 5. So this is a 19-year-old female patient, and she came with amenorrhea for 8 months, and there was an anomaly scan done at 18 weeks of gestation where the diagnosis was made as fetal renal defects, bilateral renal defects. Some say there is a cystic lesion, some say there is a hydronephrosis. So it's a mixed, confusing state. And there is also ascites. So this patient was sent to me for further evaluation, and I was quite tensed because when you are seeing bilateral renal abnormality with ascites, you should understand that your time is getting killed now because it will be a complex case, definitely. So let's jump into the picture. So we measured the measurements. Definitely, the measurements are not very accurate, but yeah, we are following the biparietal diameter because the picture looks quite good. And definitely, the abdominal circumference will be very bad because the abdomen is already distended. We can see some ascites. So get ready for some findings here. Okay, so let's look at the kidney first. So here you can see the fetal kidney. So I think this will be let me just check a little. Okay. Yeah, here you can see one kidney here, and you can see there are multiple cystic lesions here. Now the confusion arises on transverse section. You can see both here. So as it was a cephalic presentation, so on cephalic presentation, I have shown you the site determination on previous video. So let me just make a cross section of this image. So as it is a cephalic presentation, so clockwise it should be the left side. If you missed that video, just check it on Facebook or YouTube. It's available. So on clockwise, this will be the left side. So this is the right kidney. So let's look at the right kidney first. So this is the right kidney. You can see multiple cystic areas. Now the confusion arises whether it's hydronephrotic, grossly hydronephrotic kidney, or it is a multicystic dysplastic kidney. Yeah, both can happen. Both have strong differentials, but yeah, I can't see any communication between these cystic spaces. Like all are separated from each other, as there is no well understandable parenchyma here. So we will go for both, but now on cross section, you can see a very good round shaped appearance. This round shaped appearance actually goes for the cystic lesion. So this should be a cystic lesion. So this is a multicystic dysplastic kidney. Yeah, this kidney is not also good. Okay, so the right kidney should be the multicystic dysplastic kidney. Definitely hydronephrotic kidney is a very good differential. Now we have used the color Doppler. On color Doppler, there is nothing abnormality going on here. This is the power Doppler. So let's jump into the opposite left kidney. So here's the left kidney. Now this is one is quite interesting. You can see this is the left kidney. It's hydronephrotic. You can see the cystic areas. Now they have communication with each other. On my first one, you couldn't see any communication between these cystic spaces. Now you can see this is forming a very good pelvic cell system dilatation like appearance, which was also absent there. And you can see a very thin echogenic parenchyma. So this is also dysplastic kidney, and it is definitely hydronephrotic. You can see some ureteric dilatation is also present here, but not much actually. So we couldn't actually search the whole length of ureter here, but we can see some proximal dilatation at this part. So this is a hydronephrotic kidney. To see it whether it's just a low risk or high risk variety, you should definitely measure the anteroposterior pelvis diameter. So we use the color Doppler to see any prominent vascularity or something else. So there is nothing significant here. So now you can see this is the right kidney, which showed multiple cystic lesions. And this one is the left kidney, which shows the hydronephrosis. Okay, so we measured the right kidney. It is enlarged, definitely due to multicystic appearance. What is this? There's something else here also. Okay, so about the left kidney, it looks quite normal, but you can see the parenchyma is echogenic, and the anteroposterior renal pelvis diameter, which is around 9 millimeter. So as it is 30 plus weeks of 28 plus weeks of gestation, for 28 plus weeks of gestation, when you see the anteroposterior renal pelvis diameter is more than 8 millimeter or more than 7 millimeter, you'll call it a low risk variety. Like it is not the pelvic calyceal system, pelviureteric junction obstruction or something like that. So this is a low risk variety. And if it is more than 10 millimeter, then we'll go for the high risk variety. So we have the urinary tract dilatation classification. You can just easily see them on Googling it on the internet. Okay, so now there's something abnormality going on, we can understand. Now here's the picture of both kidneys. Let me show you again. So this is the right kidney, which is showing multicystic dysplastic nature. And now on the opposite side of the spine, you can see the left kidney with hydronephrosis. We call it urinary tract dilatation. Okay, so there's something abnormal. Let's look at other parts. So we can see the spine. So let's trace the spine. Yeah, spine looks quite good. Oh my God. So you can see this is the lumbar spine. It ends here. Where is the sacrum? You can see this hypoechoic area. There should be sacrum at this part, but you can't see any sacrum here. The spine ends at this part. This is the lumbar region. So the cord will end at that part. But where is the sacrum? There is no sacrum here. So now you really have to think about multiple complex abnormalities adjacent to this part. So when you can't see the sacrum, you really have to see the anal orifice. You really have to see any cystic lesion adjacent to it, which might be meningocele or something like that. So we are going to face some difficult situation right now. So here's the lumbar vertebra ends at this point, and you can't see anything here, which should be counted as sacrum. So that's a crucial condition right now. So here's the picture. You can see the spine ends at the lumbar region and there is no sacral content. On cross section, you can also see that. So on cross section, here is the iliac bones and there is no sacrum at the posterior aspect. So this is a case of sacral agenesis also. Okay, so here you can see on cross section, you go further and there is no sacrum here. You see there is no sacrum. There should be 3 ossification centers, but there is nothing here. So if you go upwards, yeah, you can see this spine. You can see this spine. Look at here. Look at it. Oh, it's not. So there is no spine at the sacral region. So it's completely absent. So this is a case of sacral agenesis. So we need to find a lot of abnormalities now. So that's why this case is about 50 slides long. So we jumped into the posterior aspect of this lower part of the body. And now you can see a cystic lesion here with internal sediments or something like that. So I was a little bit confused, firstly looking at this part, whether it's a meningocele or it's a bladder extrophy or due to some reason, or it's scrotum with hydrocele. I didn't want to say it as hydrocele for some certain reason. There is no septation. Yeah, I can say that, oh, okay. So this is a testis. This is the other sac that hemiscrotum containing fluid or something like that, but this is not. So why it is not, just let me show you. Yeah, okay, something like that. Okay, okay, okay. Just go here and see any communication with the yes. Now you can see this is the sacral region actually. So here's the communication with the sacral content. So this is a cystic area coming out from the sacral level posteriorly with internal cystic space and some sediments or something like that. So this is a sacral meningocele. So it's a lower sacral or coccygeal part. So that's interesting. This is a meningocele at this point. Okay, so let me magnify the image. Now you can see this area. This is the labia. Okay, so this is the labia. Why it is labia, we'll see it on a different view. So I have changed the setting. This is the echocardiographic setting. Oh, no, this is the linear probe. So on linear probe, we are just trying to search for this lesion and communication with the, I thought this one is the penis and this is the scrotum, but no, this is the labia actually. We'll see it on a different view, but it is coming from the posterior aspect of the lower part. So this is the sacral meningocele. Yeah, it's a little bit confusing. So here you can see the communication with the sacral region, but yeah, there is no sacral vertebra present here. Okay, so many findings. You really have to waste your time here. So here's the sacral meningocele in this patient. Okay, so these are 2.5 centimeter long meningocele. Okay, the face is the only thing and brain is the only thing that looks quite normal. Yeah, limbs were also normal in this patient. So yeah, the face looks nothing abnormal. We were looking for any presence of cleft lip, but we were confident that there will be no cleft lip in this patient because we're thinking of some abnormalities in association with this finding. So we look like the abdomen, and in the abdomen, you can see, oh, what was that? So you can see the echogenic bowel. You can see a gross ascites here. The abdomen is distended, but we can see something else there. Okay, so these are the kidneys. This is the cystic kidney, and this one is the hydronephrotic, which is not well understandable in this picture. So this is a gross ascites. Yeah, okay, but skin is not quite thickened in comparison to the hydrops fetalis babies. So the lesion should have, the baby should have some other lesions here. So let's look more. So now when we were searching, what was that? So we're looking at the liver and some other parts here. Okay, so just we are screening for any other different lesion. The placenta is posterior. Okay, but nothing abnormality is significant abnormality we can see here, unless there is something we could see there in the lower part of the abdomen. Okay, so we're checking the limbs. It looks quite normal. We think there should not be any clubbing present, but we expect to have some limb abnormalities. We tried to search for syndactyly in this patient or polydactyly. Nothing was present. So that's why we say that only the head and the limbs were quite satisfactory. Okay, so let's look in a magnified view, and you can see this is the intestinal loops. You can see the liver. You can see also the gallbladder. The gallbladder wall looks quite thickened. Let me freeze the image a little bit. By subjective assessment, you can see the gallbladder wall is thickened. Okay, it is common association with the ascites, so we are not thinking much about that. But the liver looks quite enlarged. It is appearing like a swollen structure because the right and left both sides are covered with the liver. It is very common in enlargement. So anyway, it's nothing to bother. And you can see the gallbladder wall is thickened. Okay, so these are a common association with the ascites. We thought about the fetal anemia. So we checked the middle cerebral artery. Just in a second, we could see that the middle cerebral artery is showing around 20 centimeter per second of flow. So there is no chance of ascites or no chance of anemia in this patient. Okay, so the heart rate was quite normal, 151, but we expected some cardiac abnormality in this patient. So why we are searching for cardiac abnormality in this patient? Because this is common association. So there should be some formula why we are searching for these lesions. Okay. Yeah, this is the heart. This is not a good position to do the fetal echocardiography, but if you look at the heart, you definitely should see some abnormalities here. By overall visualization, you can see the heart is occupying more than 50% of the chest. So definitely this is a cardiomegaly here. But it might be mild cardiomegaly, not a gross cardiomegaly. But you can see this is the cardiac wall. This is the interventricular septum. This is the ventricular walls, and they are thickened. So this thickening of the ventricular wall indicates, with enlargement, indicates hypertrophic cardiomyopathy or hypertrophic cardiomegaly, whatever you say. Okay, so let's jump here. So this is the thickened walls, in ventricular walls and the interventricular septal walls. You can also see them or measure them on M mode, but I'm not interested because, yeah, this is the association. Okay, so this is a case of cardiomegaly with thickened ventricular walls. So we measured with our own techniques like the transverse diameter of the chest and transverse diameter of the heart uh, in a easy and shortcut way, or in a rapid assessment. This is a cardiomegaly because it crosses more than 50%. Okay, it's not significant. By visualization is enough to say it a cardiomegaly. Now, when you are looking at the this part, you can see some pericardial effusion was present. You see more than 2 millimeter of collection around the heart. So let's see it on real time because we missed that on previous video. So let's magnify a little bit. Let's look at the heart a little carefully now. Okay, where was the so there is slight fluid. Just I tried to measure it from a different view. So there is a mild pericardial effusion, which is not a very significant finding. It should be associated with the cardiomegaly when you are seeing a hypertrophic cardiomyopathy. Okay, so many abnormalities. Like this patient is waiting for a live baby. I was very confused seeing at this case. So let's look at the amniotic fluid and surrounding part. So when we are looking at the amniotic fluid and surrounding part, we got amazed to see the umbilical cord. You see the umbilical cord here? The umbilical cord contains two arteries and one vein. Let me freeze the image a little. Now let's look at the vessel here. How many vessels are here? You can see two vessels. One should be the larger one, should be the vein, and this one is the artery. This is the vein, this is the artery. So there is two vessel in this umbilical cord. Unfortunately, up to the 30 weeks of gestation, this was undiagnosed, which is crazy. So we usually look for large congenital abnormalities, like when we solve the renal abnormalities or cardiac abnormalities, we make ourselves busy with them. But the umbilical cord contains two vessel, which is a very early pregnancy finding, and you can easily suspect trisomy 18 or trisomy 21 in these patients, because trisomy 18 is the most common association. Then second one is the trisomy 13 or Patau syndrome, where you will see the holoprosencephaly, and then there will be the trisomy 21 or Down syndrome. Okay, so we use the color Doppler and you can see two vessels. So this is confirmed that the patient is having two vessel cord. So one single, or we can say single umbilical artery. So here's the another view, and you can see two vessel here. So uh, this is a very sad thing because we are not expecting very good result from this baby. Okay, now here you can see this is the two vessel cord, and we took the sample just for a check whether there is end-diastolic flow absence or reversal. But yeah, umbilical artery is showing a good amount of flow, but still it's a single umbilical cord artery. And there is the venous flow on the downside, just for a check, not for the measurement in this patient. Now let's look at the lower abdomen of the baby. You can see the ascites, the surrounding part, and you can see another piece of heart here without any pulsation. What is this? You can see a large cystic mass. You can see some sediments here. Let me freeze the image a little. You can see the sediments here. There is a clear anechoic area and some hypoechoic areas here. So definitely there is something abnormality going on here. Now this cystic lesion made again another confusion. Like you can see, is that the dilated ureter? It should not be, because this should not be the dilated ureter. So what is this? So you can see a cystic lesion with internal thick septation and internal debris at the pelvic region. So if you see any heart like this type of a structure with internal septation, you should understand that this structure is the hydrocolpos. So it might be hemato, but no, this is the hydrocolpos. So you shouldn't get urinary bladder in this patient. Yeah, we didn't get any urinary bladder. So so whenever you see this type of thick thick wall. You can see the thick wall, cystic lesion with internal septation. You should understand that this structure is the dilated vagina with internal vertical septation. And also, it should contain dilated cervix. And you may see attached uterus in this patient with internal collection and sediment. So you can see here hydrometra, uh, that is the dilated or fluid filled endometrial cavity within the uterus. So this one is the uterus, and this is the large vagina with internal septum. What can be the common association? You may see Mullerian duct abnormality like bicornuate or uterine didelphys in this patient. Usually in perinatal stage, it's a little bit difficult. Now, usually the vaginal collection, this will contain some debris. Now, how this collection comes? Usually from the urinary bladder. So this urinary bladder, in this patient, the urinary bladder will drain through this vagina, and you will see the content as a urine. So there will be sediment, and this urine will go from the fallopian tube within the abdominal cavity and will cause ascites. So all goes here. So this ascitic fluid is from the urinary origin. Okay, so let's jump into that. So again, you can see this is the vagina, which is dilated and with internal septations. We call it persistent urogenital sinus. So this is the typical urogenital sinus, which is very uncommon finding. I think it's my first case in my lifetime. Okay, so that was very easy. So you can see dilated uterus here. So let's check it on from different view. Yeah, this is the one. Now, as the vagina is dilated and the cervix is also associated dilated, it is causing obstruction. The urinary bladder is getting compressed. So definitely you will see the hydronephrosis in this patient. So we saw hydronephrosis in one kidney, and another one will, as that one is showing multicystic dysplastic. So it's quite non-functioning one. Now it's commonly associated with ascites, that is the urinary ascites. But now you are looking at another one. You can see an echogenic bowel here. So this is the lower bowel, which is showing echogenic fecal matter here, or meconium. It may be due to the compression of the lower part of the rectum by this urogenital sinus, or it is a very common cloacal abnormality or malformation association. So, as we have seen that there is no sacrum in this patient, so its common association is the anorectal malformation or absence anal orifice. So, due to the absence of anal orifice, there might be the obstruction. So, the meconium or the fecal matter will impact at this part. So we should search for the anal orifice. So here again, you can see this is the dilated vagina and cervix region, and you can see this is the uterus containing fluid inside, that is the hydrometra. Okay, so let's look at the view again. So we searched for the anal orifice in this patient. It was not present, or we couldn't find it. We'll say that we missed it. So we tried to search it here, but it wasn't present. This one is the typical area for the anal orifice. You see, this is the one area, but we can't see any mucosa at this part. So we were a little bit confused. Yeah, it may be present, and there should be obstruction by the urogenital sinus. So it may be present and getting obstructed, or there might be some abnormality at the rectal region. So we are suspecting, but this is not the good age to evaluate that. And what we are going to show you here is this one is a female fetus, which is having some labial region here. So this is a female one. Definitely the urogenital sinus patient will have the female genotype. Okay. So this is the urogenital sinus, and yeah, the ascites is coming from the urine that is draining into the uh, um, this vagina and going to the uterus and through the fallopian tube coming out to the abdominal cavity. That's a complex thing. Or maybe it might be due to the rupture of the uterus, urinary bladder by compression by this urogenital sinus. It may also happen. We don't know. So there's a labia on this patient. So if there's a female baby, definitely uterus should not be present in a male fetus. Okay, so we tried, but we couldn't find any pure rectal anal orifice or something like that, but it may be present. Okay, so there is no limb defect. The amniotic fluid looks quite good. There is a good amount of amniotic fluid, which is very important here because, yeah, the fluid is playing very crucial role. So as the amniotic fluid is having a good amount, so there should not be complete obstruction of the urinary bladder. So if there is no urinary bladder, there is no functional kidneys, the amniotic fluid should be almost gross oligohydramnios. So as you can see, there is no feature of oligohydramnios. So definitely the bladder should be present or urine output should be present. So we couldn't find any urinary bladder in this patient. Even we couldn't find any stomach in this patient. We tried to search for the stomach for 45 minutes, but we couldn't see any stomach in this patient. So we tried to see any small size stomach or something like that, but it is not present. We thought that there should be any esophageal atresia, but the neck region is not well understandable. We couldn't go for that due to the age and position of the fetus. So the amniotic fluid is quite good. It might be associated with the urine production, but both kidneys doesn't look quite normal. So we are not expecting much urine production in this patient, but still we are expecting some. But the amniotic fluid is quite enough, like 16 centimeter for amniotic fluid index. So we're suspecting any esophageal atresia or maybe associated tracheoesophageal fistula, whatever. So there might be some upper GI tract obstruction in this patient. Okay, so anyway, so let's look at the urinary bladder. We were searching for the urinary bladder at the lower part. We put the color Doppler and you can see the tiny vessel pulsating here is the single umbilical artery or single internal iliac artery at this level. So there is no typical distended urinary bladder. Even 45 minutes of examination, we couldn't find any bladder here. So bladder might be ruptured or it may got displaced. So here you can see a cystic area. Is it the stomach? Yeah, it can be the stomach, but no, it is the cystic lesion which we found as a renal cyst. Okay, so this is not the stomach actually. Okay, so here we can see the fetal limbs. This is the upper limb with the fingers. We were expecting some syndactyly, but there is no syndactyly. The fingers are separated from each other. Okay, so why it's not getting ended? So here's the overall view of the fetus. Now you can see multiple abnormalities in this patient. So what can be the association and what can be the diagnosis in this patient? So you have seen a lot of different abnormalities like ascites, bowel abnormality, echogenic bowel or bowel something obstruction. You have seen urogenital sinus, multicystic dysplastic kidney. You have seen hydronephrosis. Bladder is completely absent or ruptured, or it is draining into the vagina through which the fluid is going through the fallopian tube into the abdominal cavity forming ascites. There is sacral malformation or absence with sacral meningocele. So if you think about the single umbilical artery, first thing that should come in your mind that when you see the cardiac and renal abnormality with a single umbilical artery, the first thing is the trisomy 18 or Edwards syndrome. And as it has many other abnormalities, definitely Down syndrome is also a very important differential. So we can evaluate it with the amniocentesis or something like that. But yeah, in this patient, the termination is the first thing that should come in your month. But unfortunately, it's already 30 plus weeks of gestation. Okay, so you can see this echogenic stagnant bowel. So obstructed bowel. So the distal bowel, that is the lower part of the sigmoid or rectal part. So it is showing internal fecal matter here. So it might be obstructed due to the absence of anal orifice, or if the anal orifice is present, it is obstructed due to the compression by the urogenital sinus over the rectal region. Okay, so you can see this echogenic part, this is the fecal matter within. Here's again, now you can see this echogenic fecal matter. It is just associated or adjacent to the urogenital sinus. So that's why we are thinking more about the compression by this lesion. So, so that was the report actually. So it was 29 to 30 weeks of single live intrauterine pregnancy with cephalic presentation and adequate amniotic fluid. Make sure the reporting style is quite different from country to country. So many of you are connected from different parts of the world. So that's why the report format or style may vary each other. So anyway, we have found multiple congenital abnormalities like single umbilical cord artery, hypertrophic cardiomyopathy with mild pericardial effusion. So hypertrophic, I think I have just copied it, so there should be a C here. Okay, so sacral agenesis with sacral meningocele, hepatomegaly with thick walled gallbladder, non-visualized stomach. We have checked it for up to 45 years, so we are expecting esophageal atresia or something like that. But this age with this setup or this position, esophageal evaluation was not satisfactory. There was echogenic fecal matter at the distal part, and we couldn't find the anal orifice, but we're suspecting it to be having an anal orifice, but we're not sure because of age and position. And obviously, the sacral malformation or compression by the urogenital sinus will need to be evaluated. It should be evaluated previously. Okay, so there is a multicystic dysplastic right kidney, and as well as there was a dysplastic left kidney with urinary tract dilatation and ipsilateral proximal hydroureter. As the anteroposterior renal pelvis diameter was 9 millimeter and it was a 28 plus weeks of gestation, so we call it the urinary tract dilatation A1, that is the low risk type. So there was persistent urogenital sinus, and bladder we couldn't find. So the gross ascites may be due to the abdominal, maybe due to the result from the escape of urine through the fallopian tubes, which came from the vagina, uterus, and the vagina is getting fluid from the urinary bladder. And again, there might be bladder rupture association, but it is very uncommon. Okay, so we recommended it to be a Vactril association or aneuploidy, that is the trisomy 18 or 21. So these need to be excluded or evaluated. Okay, so in Vactril, you'll see the vertebral abnormality, anorectal malformation, cardiac abnormality, tracheoesophageal fistula, and renal abnormality, and esophageal, definitely, and obviously the limb abnormality. We didn't find any limb abnormality. So there might be Vater or something like that. In Vater, you will see VATER. So there will be the vertebral abnormality and A for anal, T and E for the esophageal, and there will be the R for the renal abnormality. Okay, anyway, so that's all for today. And no, that's not all for today. We'll go for a tiny bonus part. So we have already crossed 1 hour actually. So I think this case is very beneficial for many of you who are trying to complete all the congenital abnormalities, and a single case has everything that you need to know. Okay, so the bonus part, your head is just thinking about so many congenital abnormalities. So we will just talk about the cloacal malformation or urogenital sinus in this patient in this time. So yeah, that was the case of urogenital sinus. So we want to share some points about this case. So it's a complex malformation. Definitely, you'll see the congenital hindgut or genitourinary abnormalities, and definitely it's due to the cloacal division failure. The cloaca means the sphere, the stool-like things, and in ultrasound, you will see the septated retrovesical, that is the beside the behind the urinary bladder, a cystic mass. Maybe it will show you some sediments or fluid level, or you may see some septation inside. So this is the hydrocolpos, and the uterus may be associated with dilatation containing fluid. Okay, so maybe you will see two uterus or uterine didelphys, that is the Mullerian abduct abnormalities. You may see a single uterus. So this is on ultrasound, you will get the cystic pelvic mass, and there will be fluid level or hazy internal content. It may be due to the vaginal secretion with or without meconium, or maybe it will be mixed with the urine, which is a common association. So the vertical septum is almost seen in 80% of cases. So, and definitely you should search for the uterine abnormalities, which is usually not easily understandable prenatally. Now, on about the as it is known as urogenital sinus, so about the uro part, you may see some renal abnormalities, and commonly due to the obstructive nature and compression over the bladder and ureter, you will see the bilateral hydronephrosis, or a common association is the multicystic dysplastic kidney. You will see multiple cysts within the kidney, and the echogenicity of the kidney may get increased due to the failure of these kidneys. And there might be some uteropelvic obstruction, definitely, and the kidney may have ectopic location or agenesis. If you look at the bladder, it's very important. The bladder will be absent or decompressed. It may get ruptured actually if you can compress at the best lower level. But usually it has got a connection with the vagina, so the urine initially drains into the into the vagina, and through which it goes to the fallopian tube and goes to the abdomen. So ascites is commonly formed by the urine through the fallopian tube outside the outside the uterus and bladder. So the ascites is definitely from the urinary part, and urinary ascites from the black flow through the fallopian tubes. So there might be bowel distension or obstruction depending on where the urogenital sinus is compressing, or there might be some absence of the anal region, and the genital is definitely has a chance of getting ambiguous nature. Oligohydramnios, yeah, it may occur if there is no association of the tracheoesophageal fistula, or due to the renal compression or renal abnormality, it may happen. And yeah, you should search for some congenital abnormalities like cardiac, spinal. Yeah, we have found spinal here, and limb defects are also common. So we have some classification. Whenever you get a very uncommon case, you really have to search for the staging or grading or classification on internet. That is the easiest way to memorize those things. So we have some classifications here, but we actually don't go for them on ultrasound. Rather, these are for the pediatric surgeons. So it depends on the some measurements and calculations. So we don't want to go for that because this is not for us. This is for the pediatric surgeons. So let's end it with just two pictures that is taken from the books. So you can see the lower part of the abdomen showing a septated cystic lesion. There's a vertical septation here. On color Doppler, you will see the arteries are the umbilical arteries are, or internal iliac arteries are on the lateral side from these cystic lesions, and they will form a single vessel, that is the umbilical cord arteries. So on both sides they should be present, but in our case there was a single umbilical artery, so only one part of the internal iliac artery was present in this patient. So we have took this as this lecture from this book. So this is an excellent book for if you are searching for any congenital anomaly evaluation in a better book. This one is the best one. So you can just search it, or just go for buying this book. So we highly recommend, if you are interested in congenital abnormalities or obstetric imaging, you should definitely check this book. Okay, so thank you for joining me, and our next session, our next session will be on 24 January 2025. Yeah, I don't know why my video is showing 2024. I think I have just wrote it wrong actually. That is common. Okay, in January 24, in my area, there will be a religious program or something like that. So there will be huge noise at this part. So if we face it difficult about the noise, so we may have to close this session, or we may take this session on 23rd January. So we will just make a notice prior to this session. So don't worry about that. So hope to see some interesting cases at the time. Hope for that. If you're from my country, we have a session on breast ultrasound. Yeah, it's a hot topic for many of you. I'm not very interested, but yeah, I have to take this session. So it's a paid session for only the local people. Many of you asked about taking it for the foreigners, but yeah, we have already said that the payment system and the refund system is still not available and not good or fruitful for the foreigners. And also this is conducted in our local language, so it's not suitable for the foreigners. So don't worry, we'll arrange more interesting cases for you, so that will be enough, I think. Okay, so anyway, so if you are from my local country and you are interested, you can join this session. Also, we have got our YouTube channel named Imaging Study, where we have already uploaded our previous sessions. So don't forget to check them if you have missed them. We already have around hundreds of cases there in last 2 months. So you can just enjoy them. And also we have got 470 videos already uploaded along with 61K subscribers, which is crazy. I really didn't think about this amount of subscribers for a YouTube channel like this, because it has a limited audience, who are interested on ultrasound. And my targeted subscriber range was around 20,000. So 61K is crazy for me. Okay, so anyway, we have also got a imagingstudy.com website. Though I'm very irregular for managing this website, I forget every time, but you can check that. So thank you for joining me, and yeah, it's great to find you all. If you have any question, you can just ask me in my live session, because yeah, we have posted this video, I think, in many different groups, but obviously I can only see the live content here in my this part. If asked about the medullary sponge kidney, because a medullary sponge kidney is a developmental defect, so better for the adult elderly patients, we go for the medullary nephrocalcinosis, because this is the common, and more than 80% cases you'll get the medullary nephrocalcinosis. Yeah, any question, please? Thank you. Yeah, it's a long session about the anal orifice, actually. Just posterior to the scrotum or the labia, we see the anal orifice, like there is a ring. There should be a ring. It's very difficult to demonstrate with my own hand, because it is not the anus of mine. So there should be a hypoechoic outside ring, and there should be an inside echogenic part, which is the anal mucosa. So hypo and hyper ring should be present, which is the normal thing. And if it is not present, we go for if the mucosa is absent, echogenic mucosa at the central part, we go for the anorectal malformation with the proximal obstructive features also. Okay, asked about the okay, so uh, about the cervical polyp, if there was any history of bleeding, yeah, we think about the malignancy definitely. We told you that if there is a if there is a single supplying artery, this should be counted as a cervical polyp, but we don't want to keep the cervical polyp. So that's why we try to remove it, because we always try to be careful about the cervical lesions, because cervical malignancy is very high. So about the breast and about the cervix, we are very careful. So though it looks like a benign lesion, our surgeons and our clinicians, they want to remove it because we don't want to take any risk. So if there is bleeding, definitely there should be some ulceration within the cervical polyp. So you really have to remove it, okay? Because if it is still not a malignant lesion, we don't want to make it a malignant lesion, as there is a chance of ulceration when there is a chance. So when there is a history of bleeding. Thank you. Yeah, anal atresia can be diagnosed prenatally. We can diagnose anal atresia, jejunal ileal atresia, obviously the duodenal atresia, and definitely pyloric stenosis. It's very uncommon, so we go for the duodenal atresia, and definitely we can diagnose the esophageal atresia. But this in this patient, it was not a good time. Like it's 30 plus weeks of gestation, so it's crazy difficult for evaluating this patient when the baby is in this type of size. So it was a little bit frustrating. If I could see this case earlier, then we could find some more lesions. But make sure the urinary or the dilatation of the vagina may not be well understandable in very early age. It may be present, but it may not be understandable, because more ascites, the more the lesions are demonstrated. So that made some confusions there, I think. Ye- Okay, about the cystadenoma and ovarian cyst, we go for the URET's classification. Uh, if you see a cystic lesion, it might be mucinous or serracystadenoma. It might be something else also. So there is a URET's scoring system where you can just put it as a complex cyst and go for the URET's scoring. Nowadays, in my country or in my setup, we go for the go for it as a cystic lesion or ovarian style we go for right now. We don't actually report it in as cystadenoma, mucinous, or serous, whatever it is. We don't want to go for it, except for the typical ORS2 cysts like uh, hemorrhagic cyst, endometrioma, and dermoid cyst. We want to report it, but otherwise we just try to stop it as a complex cyst, cystic mass, cyst, and then we go for the ORS scoring. And uh, anytime you see a bowel lesion, uh, this is the bowel malignancy, you will go for the wall thickening. So you will see the increased wall thickening. The wall may be irregular also, if it is well understandable. So there will be a thickening of the wall with increased vascularity. There might be some associated surrounding fat plane irregularity or thickening. So we go for the bowel wall thickening, or there might be some mass-like appearance, then we go for the bowel mass. But CA colon should be diagnosed histopathologically, and obviously with association with the CT. Nowadays we go for the CT, contrast CT, and that is very great. And obviously the colonoscopy. Don't forget about that. That's You have asked for the tech tracing. That's a little bit difficult, but it's not very difficult, but it needs practical demonstration, I think. Okay, no problem. We'll try to make them. Let me check the questions. Fortunately, today I'm getting some questions because on previous sessions, there was no questions from the audience. It's very difficult to contact me. I have many people connected to me right now from my own country, and they know how much difficult it is to contact me, because I'm almost 24 hours not available on phone because of certain reasons. It's stressful. Okay, just checking the previous questions. Okay, so many of you are connected from very far away from my own country. So it's very interesting, and I'm very grateful to you. Okay, thank you, thank you. Yeah, I'm well unavailable. Yeah, about the India, I had I've registered for us Asia Oceanian Congress of Radiology 2025 in just happening next week in India, Chennai. But I didn't get any visa for that, unfortunately. I have a paper there for presentation, but unfortunately, I'm missing that. And I have also many friends there from different parts of the world, especially the Asia Oceanian region. But I'm going to miss them there. If I could be in India in next week, then I could say that, yeah, you can meet me there, or I could meet you there. Yeah, yeah, we have already uploaded some MSK cases on our previous case sessions, but today, due to the last one, we tried to take small cases today from the first one to the fourth one. The fifth one is the largest one, so we took small cases for the previous ones. Yeah, we'll include MSK cases definitely. Okay, yeah, I'm from Bangladesh. I think it's far away from many of you connected from your country, from very far away from my own country. And I'm very grateful for that. Okay, so I think the questions are over, and already we have crossed around, yeah, 1.5 hours. So thank you for joining me in this session. I hope to see you on the next one in the next week, 24 January 2025. And till then, thank you for joining me. And you'll obviously find this video available in my YouTube channel from tomorrow night. So thank you for joining me. Hope to see you soon. Good night. Have a nice day.